Hi, my name is Dr. Christian Ruff, and I'm the Director of General Cardiology at Brigham and Women's Hospital. And I'm also a clinical trialist and have done a lot of work in anticoagulation, both for stroke prevention and atrial fibrillation, as well as the treatment and prevention of venous thromboembolism. And as we know, anticoagulation is very effective in both of these disorders, but there's been a lot of questions about the implementation of these drugs in patients with a variety of comorbidities. And there's been particular interest regarding the ability to use these drugs in patients who are overweight, particularly patients who are morbidly obese. So let's first of all talk a little bit about definitions. You can use body weight or BMI. When we're talking about very obese patients that we're concerned about with anticoagulation, generally people have used thresholds of a BMI of 35 or above, certainly 40 or above, or a body weight of 120 kilograms or above. And there had been some data that suggests that due to differences in volume of distribution, that the concentrations of both the 10A and 2A inhibitors were less in patients who had a BMI potentially above 35 or 40, or patients who had a body weight of 120 kilograms or above. And there was a concern that that lower concentration were going to lead to an increased risk of thrombotic events. And I'll tell you my summary of both the clinical trial data as well as the real world data in patients who are obese and in patients who are morbidly obese. It turns out that although the drug concentrations may be slightly different and maybe a little bit lower, the therapeutic window for these drugs is very wide, much wider than, say, warfarin, where we're targeting a very narrow INR between 2 and 3. And that although there may be differences in concentrations by 10% or a little bit more, that there isn't any data that suggests that those small differences in concentrations lead to a loss of efficacy. In fact, obese and morbidly obese patients have some of the lowest event rates, both for stroke and bleeding, particularly in patients with atrial fibrillation, and similar trends are actually seen in patients who have obesity and venous thromboembolism. And so although there have been guidelines, and most notably the International Society of Thrombosis and Hemostasis, one of the hematology guidelines, that cautioned people not to use the DOACs in patients who had a BMI of above 40 or weight above 120 kilograms, the data suggests that these drugs can actually be used quite safely in those patients. And I think in the totality of evidence, particularly in the atrial fibrillation space, that there is now convincing data from clinical trials, both the Aristotle trial with apixaban, the Engage trial with edoxaban, and particularly for the 10A inhibitors, that shows even at the extremes of body weight, patients with a BMI well above 40, that these patients do very, very well, and there's no loss of efficacy in these patients. So my conclusion is the totality of the data and the guidelines have now generally broadly supported this, that there really is no weight or BMI threshold that you should withhold these agents. Across the entire range of weight and BMI, these drugs show preferential advantages with respect to warfarin and other vitamin K antagonists. And that's largely due to the fact that these drugs have very, very wide therapeutic ranges with respect to their concentration. And so although there may be very small differences with respect to the concentrations in obese or morbidly obese patients compared to normal body weight patients, that does not translate clinically into any meaningfully different. So I hope that's been helpful for you and convinces you that these agents really can be used in the vast majority of patients regardless of their underlying comorbidities. Thank you.